Welcome back, friends. So we'll continue the osteology of lower limb. So in this session we'll do the patella. It is also called the kneecap. It's a very small topic. It will not take much time and very easy to understand also. Now this is the commonest bone which is asked in the lower limb in your viva, just like clavicle in your upper limb. This is the commonest bone to be asked in lower limb is the patella. So let us learn about patella. Now patella is also known as, in simple layman term, kneecap. That is the largest sesamoid bone. It is a bone which is developing within the tendon. It's the largest sesamoid bone. In the whole body, and this is, since it is a sesamoid, it should be found in some tendon or muscle. So tendon of quadriceps femoris. Now till now we came quadratus femoris, but this quadriceps femoris we are hearing for the first time. Quad means 4, sep means head. So it's a muscle which is attached to the femur, thigh bone, with 4 heads. So what are these 4 heads? So in this, the 3 heads are from your vastus. So vastus lateralis, vastus medialis, and vastus intermedius. Apart from these 3 heads, the 4th head is your rectus femoris. So if you put all these 4 muscles together, all these tendon together, they have a common insertion. So that is why this is what we call tendon of quadriceps femoris. I will be showing you this also. So within this tendon of your quadriceps femoris, the patella is developing. So since it is developing within the tendon, it is not having a normal ossification. So this bone do not have periosteum. So periosteum is absent because of its special development. Since periosteum is absent, these fracture cannot heal naturally, so we need to suture them. So suture in order to allow or facilitate the healing of a fracture. Otherwise, if a broken patella will not heal because of absence of periosteum, because periosteum is the one which has a cellular layer which help in growth of the osteocyte, which bridges the gap, fracture gap. So now let me bring the bone here. So that's our bone. Now where is the location of this bone? So the bone is located. It is located in front of, here you can see. So location, it is front of knee joint. Because of the same reason, that is why it is a cap in front of knee. That is why it is called as a kneecap. So structure wise, it is a flat bone. So it is a flattened bone, and if you see the shape, it is more or less, if you look at this, it's triangular. So it is flattened triangular bone. When we say triangular, a triangle will have a apex and a base. So in this case, you can see the apex is pointed downward. So here you can see in this anatomical position, apex is this is apex which is pointed downward, and this is the base which is pointed upward. And it has surfaces and borders are there. But the surface which we are seeing right now, this is what we call as a anterior surface. The surface which you can actually feel just beneath your skin. So it has got a, on the anterior aspect, it is convex. And if you touch the bone, it will be rough. Whereas if we see the posterior aspect, if we turn this bone, this is the posterior aspect. Here the posterior aspect is, it is smooth. Now It is smooth because it is articular, covered by hyaline cartilage. So this is the posterior surface. As it is, this is the apex and that is a base. Now in this view, if you notice, here there is a line which is passing, a vertical ridge which is passing here. Now this vertical ridge is dividing the entire posterior surface into a smaller medial part. This is a small medial part which is 1/3 of it, and 2/3 of it is your larger lateral part. So that's a division on the posterior surface. Now with these things in mind, we'll be able to decide the side. So anatomical position and side determination. Now we'll bring the bone back again. So both the surfaces. So this one is your anterior surface, this is the posterior surface. Now you have to hold the patella in such a way that the apex should face downward. Apex is facing downward. This is one part, and the second thing is the base. This is the base on the top. Base should face upward, and the articular surface, that is a smooth surface. This is posterior surface, this is the articular surface. So this should face posterior. So articular surface should be behind, posterior, in which again in this articular surface also, if I put down the articular surface here, a vertical ridge which is dividing into a medial 1/3 and the lateral 2/3 area. So you have to hold the articular surface posteriorly in such a way that this large lateral part should lie laterally. This will lie laterally. So when you put all these things in position, so if you keep the patella on any table with the apex downward and base upward and smooth surface behind, so you will notice that the patella will tilt. So there will be tilting of patella if you do this. So patella will tilt to one side. So whichever side it is tilting, bone belongs to side of tilt. And we know the bone will tilt towards your large lateral 2/3 area because this area has more support. So the bone belongs to the side to which the patella tilts. So this is your anatomical position and side determination. Now let's see what are the features and attachments. Features and attachment of patella. Now we said it has got apex, then there is a base, there are borders, there are surfaces, all of this we'll see. So first we'll again get the image back. This is the anterior surface. And this one is our apex, and this is the base. And we are seeing the anterior surface. What do we have here is, we got, there is the apex is, the patella has the following feature. It has got apex. So about apex, then other than apex, it has got three borders other than apex. Apex is pointing downward. It has got three borders. The borders are, there is a base. Base is also called as a superior border. So superior border is the base. So one is your superior border, also called as a base. Then One is medial, other is lateral side. So if you see posteriorly, we know whichever side is a larger lateral area, you will call. So this is right patella, so this should be the medial. This is your lateral. So somewhere at the back, you will be having a vertical ridge dividing like this, a faint ridge. So thereby, so I will call this border as a lateral border, and this border will be a medial border. So it has got a lateral border and a medial border. So there are three borders are there. You have two surfaces are there, which I told you in side determination. One is your rough anterior surface, which you are seeing right now. Another one is smooth articular posterior surface. There are two surfaces are there. So we'll be studying the patella under all these features. So one by one we'll see the features. First is about the apex of patella. Apex of patella is directed downward. So it is directed downward in anatomical position, and it is provide attachment. So it is directed downwards, and the attachment is, it gives attachment to one ligament, and that ligament is starting from here all the way, it goes down, and it attaches, this ligament goes down and attaches to your next bone down. The bone which we have down is our tibia, so it is to the tubercle of tibia. This attaches. I'll show in the picture also. So tubercle of tibia. So attachment is, name of the ligament is called Ligamentum Patellae, or simply called as a patellar ligament. Ligamentum Patellae, also known as patellar ligament. What is it extend from? It extends from the apex of patella to the tubercle of tibia. So let us see the ligamentum patellae in our application, how it looks like. Now before I go there, so ligamentum patellae is exactly, so what exactly is your ligamentum patellae? So this ligamentum patellae is our, one second, I think pen is not detecting. So I was telling ligamentum patellae. So ligamentum patellae is the extension of your quadriceps femoris. So your rectus femoris, vastus medialis, vastus lateralis, and vastus intermedius, all these tendons come down and they insert onto the various locations or borders of the patella, and then it continued down from the apex as a common tendon, and that common tendon is what we call as a ligamentum patellae. So let us see now in the app. Patellar ligament or ligamentum. And that's a patellar ligament, you can see, also called ligamentum patellae. If you see the isolate view, you can see. So there's a ligament which is starting from your base apex of the patella, you can see from the apex, and it is going all the way down to something called as a tubercle. So that's a tibial tuberosity or tibial tubercle. So I can show you this again on this side. If you see here in this image, you can see here is our ligamentum patellae, and this is how it is going. It goes down and attaches there. So here you got your tibial tubercle or tubercle of tibia. So this is about your apex. Now let us go to the borders. We said there are borders of patella. There are three borders are there, including the base. So this is what we call base or superior border. In this we are seeing lateral and medial. So this will be a lateral border. This is the medial border. So your superior border, also called as a base, I told you, and this border is providing attachment. On top of it, it is actually having some area. So this area provides attachment. So if this is the top view of your superior border, so superior border provides attachment to two muscles on its top. In its anterior part, it provides attachment. A muscle called rectus femoris. This we did even the hip bone, straight head and oblique head, and it is posterior part. One more muscle. Now this muscle is your vastus intermedius. So these are the two muscles on the base or superior surface, anteriorly rectus femoris and posteriorly vastus intermedius. So if we go to the app, and now here we can see quadriceps tendon. Now you can see here. Now can you make out this one? So this is, I just isolate this. Now, here you can see that is the superior border, and so this is, here we have the superior border or the base of patella, and in the front you got rectus femoris tendon. The muscle is not shown here. The back you have the tendon of vastus intermedius. So these are the two tendons which are coming down and inserting into this. So if you have to see this, both this tendon also, you can again put down this. So vastus intermedius, right, and rectus femoris, right. Now if you see in this figure, you can make out now that is the entire. So now if we just select and isolate, now you can see these are the two, and I will bring the patella also along with it. So and ligamentum patella also. So you see all of these are there now. The side view you see. So let us take, now this is again, here you got two heads, that is straight head and reflected head. So this is your straight head of rectus femoris. If you go back to your hip bone, you will know what I am talking, and this is the reflected head of rectus femoris. Anyways, both head have combined and we have now single rectus femoris muscle, and it comes down. This is the tendon of rectus femoris which is inserting to the, this is the tendon of rectus femoris, and here it is inserting to the base in the anterior part. So posteriorly you see this one is our vastus intermedius. Yesterday we have seen in the femur anterolateral surface, the tendon is again here. This is a tendon of vastus intermedius inserting again to the posterior aspect of the base. And if you see from the apex, you have ligamentum patellae, also called as a patellar ligament, which will go and attaches to your tibial tubercle. So this is here apex and base. Okay, now back to this. So we are done with the base. Base will give attachment to two muscles. So in this, I have to draw, I'll call this as in the anterior rectus femoris. The posterior I'll call vastus intermedius tendons. So these are the two things which are inserted into the superior border. Now let us talk about the lateral border. So lateral border of patella. So here we are calling this as a lateral border. So this lateral border is giving attachment now. You provide attachment to your vastus lateralis. This origin we have seen here in the previous class. So this is attachment is, it is to the upper 1/3. So vastus lateralis attachment is upper 1/3 of lateral border. So if this is here, if I put it here, so upper 1/3, this is our part of it. So what happens in case of base? So this is your vastus lateralis. So 2/3 of the vastus lateralis is inserted to the base only. It is on the base, whereas the lower 1/3 is inserting to lateral border, and the remaining part of the lateral remaining lateral border, that is your lower 2/3 of lateral border, gives attachment to an extension of your vastus lateralis that we call as a lateral patellar retinaculum. So lateral patellar retinaculum is a aponeurotic extension of your vastus lateralis inserted to the lower 2/3 of the lateral border, whereas in the upper 1/3 you have the vastus lateralis, whereas the remaining part of the vastus lateralis is actually inserting into your base only. So if you see base has got rectus femoris anteriorly, vastus intermedius posteriorly, and in the lateral part you got even the 2/3 part of your vastus lateralis. Similarly on the medial side you will have now a muscle. Now this is exactly opposite of your the muscle. So this is the medial. So this muscle is vastus medialis. You see your upper 1/3 is inserted to the base, whereas your lower 2/3 is inserted to the medial border, and the remaining part is your medial patellar retinaculum. So thereby here this was your lateral patellar retinaculum. So lateral and medial patellar retinaculum are the aponeurotic extension of your lateral and medial vastus muscles respectively. So I already told you about the medial border also. So medial border provides attachment to your, again, the upper 2/3. So this one is your upper 2/3. So muscle, whereas your some part of the muscle is into the base. So you can say this one is your part of the muscle in the base, so remaining muscle. So 2/3 of the muscle of vastus medialis is here, and then that's the remaining 1/3 of the border is to the retinaculum of vastus. So this is about here. So thereby you can say lateral and medial patellar retinaculum are the extensions or expansion of the tendon of vastus lateralis and vastus medialis on either side. So these are your medial border. So you can say medial border upper 2/3 gives attachment to vastus medialis, whereas the lower 1/3 of the border is giving attachment to a retinaculum, which we call as a medial patellar retinaculum, which is the expansion or extension of retinaculum of vastus medialis. Next, surfaces. There are two surfaces are there, surfaces of patella. So first we look at the anterior surface. So this is the anterior surface, which is very simple and straight. So anterior surface, we said it is rough compared to posterior. It is convex. You can put things on it because posterior surface is flat, more or less. So this is convex, and it is striated. You see there are so many striations are running. So longitudinally it is striated. And very importantly, you can feel it. You can just touch your patella and see. Extend your knee and touch the patella, you can feel the anterior. So thereby it is just beneath the skin, so you can call this subcutaneous. And if this is your skin and this is your anterior surface of the patella, in between them you got a bursa. So there is a bursa between the skin and the anterior surface of patella. So this is subcutaneous because it is beneath the skin, so it is called subcutaneous bursa in front of the patella. So subcutaneous pre-patellar bursa. So subcutaneous pre-patellar bursa is present between the skin and the anterior surface. So we have to see now one bursa which is lying in front of it, that is subcutaneous pre-patellar bursa, and we have to see even those retinacula. So let us go to the okay. So I have to add vastus so vastus medialis and vastus lateralis. Vastus medialis right, vastus lateralis right. Now look at this. So this one is your vastus lateralis, this is your vastus medialis, and in the front what you are saying is the rectus femoris. Behind will be your vastus intermedialis in a deeper plane. So you see all these tendons are coming. Here two tendons will come, front and back, and here they are inserting. So you see a part of it coming to the base, and this is entirely to base, and some portion is going to the borders. Apart from this, you also see that these two bands on this side and these two bands on this side. So the band on the lateral side is your lateral patellar retinaculum. Similarly, this is your medial patellar retinaculum. In this picture you can see these two are your medial patellar retinaculum, and here these are your lateral patellar retinaculum. Now let us show you in a separate view. Now if I isolate this, you can see these are your lateral patellar retinaculum. There are two bands are there. These are the aponeuroses of the vastus lateralis. So if you see their attachment, they attach from your upper part. You can see from the anterior and other from the lateral condyle of the femur, and both come down and they are attaching to the tibial tuberosity. So this is different. So this is the tuberosity. Tubercle is different than the tuberosity. You can see here. So this one is what we call, this is your tibial tubercle is here. Another one here is there. This is also coming to the same part. You can call as a tuberosity of tibia. Both are same only, just the extension. It is a very big tubercle is there. The same thing on this side also we will have the attachment, but that attachment will be from the medial condyle or epicondyle of the femur to the medial condyle of the tibia, not to the tuberosity. So let us bring the other one also. So this one. So again, if you see this view, there is also double band. So again from medial condyle to the tibial condyle. And if you bring both the capsule, both the ligaments, now you can see these are the two, medial and lateral retinacula. These are your extension of the muscles. And if you want, this is the lateral we bring and medial we bring, and then you isolate, you will know these are the extension from the same. Okay. Okay. So this is about. Another thing is, I even told you that the anterior surface, it is subcutaneous, and it is, now you can see here it is attached to a patella. So here you can, patella is subcutaneous. Here you have a bursa is there. So in this case, if you see, this is your pre-patellar bursa. Here also you can see very clearly on this side, prepatellar bursa, which is subcutaneous bursa. Okay, so this is about your anterior surface. Now let us go to the posterior surface. So anterior surface is simple. The posterior surface. Posterior surface is slightly complex because it is articular. So this is the posterior surface. So posterior surface is, in this also if you notice, this is your lower 1/4 area and this is your upper 3/4 area. So if you see the upper 3/4 area, it is smooth and it is articular, whereas your lower 1/4 area, if you notice, it is actually rough like your anterior surface. So whenever it is rough, it will be non-articular. The small non-articular area is present near the apex. This itself is further divided into two areas, upper and lower area. So this small area near the posterior aspect of the apex is again divided into two parts, an upper and lower area. The lower area is a lower area and that is an upper area. So lower area is for your ligament. So that ligamentum patella is attached. So we said it is attaching from the apex. From which part of the apex? From the posterior surface, lower part of the apex is your ligamentum patella, which provides attachment, whereas the upper part is related to your pad of fat. This we call as a infra. You'll have just a pad of fat. This pad of fat also you can feel. In your knee extended, you can feel that soft thing what you have at the apex is your infrapatellar pad of fat. This both I will show again. So this is about your lower 1/4 area. Now your upper 3/4 area, which is smooth and articular, so that itself is again divided by a vertical line. So I'll bring the better picture here. Yeah, this picture will do. And this is the posterior view of patella. We are seeing posterior view. So this was your lower 1/4 area where we told to ligamentum patellae and to the fat. Now upper 3/4 area is articular and it is divided by a vertical line. You see there is a vertical line here. So this vertical line, a ridge, divide this entire area into this entire part which I am shading now. This entire part is your lateral 2/3 area and your medial 1/3 area. So the entire upper large articular area is primarily divided by a vertical ridge into a large lateral and a smaller medial area. Now this large lateral area, this area will articulate with your lateral articular surface of femur. If you remember the femur, if I bring the femur bone here, and you will notice here, you see this is your lateral condyle and this is the medial condyle, and you see the lateral condyle is little bigger compared to the medial condyle. So the lateral 2/3 of the patella is articulating with this lateral condyle anterior surface, and the medial one will articulate with the smaller medial condyle. So the corresponding surfaces will occupy. So in between them, that vertical ridge which I told you just now, this vertical ridge which I mentioned to divide, that vertical ridge also will take up this gap here. So it also will occupy the groove on the patellar surface of the femur, and this is only when patella is in extension. That means when you keep the patellar groove will occupy, that means this vertical groove will occupy in knee extension. When you keep the knee extension, the groove also goes in between. So that is the occupation. Now if you see the larger area again, your larger lateral area which is lying in contact with the lateral femoral condyle. So this is again in all. So this entire area, the entire part it remains in contact with the lateral articular area in all the positions of the knee. Here you can see this is again divided by two faint ridges. You see this one faint ridge here, the other faint ridges into three areas, 1, 2, 3 areas. So you see the upper area on the lateral part, this is in contact with your lateral condyle during ordinary flexion. Right now if you are sitting, this is the part which is coming in contact. So let me put this patella along with this. Okay. Now let us see here. So this is the part, this area is here, this is during your normal ordinary flexion. So this is the part here also. Same thing, the division here is, this is again we can see. So this is the part here. We can divide, this is our vertical ridge, this is your medial area, this is your lateral. Lateral area is divided by two ridges. So this one is the part. So this is 1 and 1. So this is during your ordinary flexion. Then during semi-flexion, so when you are half 50% flex knee, if you see the middle area number 2. So here you can see this is the part when it will come in contact, and when you stand, that is an ordinary extension. So that is your number 3. So this is the number 3. So this entire lateral part is coming in contact with this area. So there is only a small medial area is it. So medial to this vertical line, you got the medial part we said. Now this medial part is further divided by another line. Do you notice that one more line is the medial part is further divided by another vertical line into a small medial area. Now this part will come in contact with only the medial femoral condyle only in the full flexion of the knee, whereas the remaining part of your lateral part of your medial area will behave as just like your lateral part. So thereby you can entirely divide your entire patella first by your lateral into your lateral 2/3 and medial 1/3. The lateral 2/3 is divided again by two oblique ridges into three areas, and this will be in contact with the lateral articular area of the femur in all the positions of the flexion. Now the medial part is again further divided by one more vertical ridge into a smaller medial strip. So we can call this the medial 1/3, and this we can call as a lateral 2/3 of the medial area. So medial one strip will be coming in contact with the femoral condyle only during the full flexion of knee, whereas this part will behave just like the remaining lateral area. So that means it is coming in contact with the lateral condyle of the femur in all the positions. So this is all about here. So thereby you can say the patellar surface of the femur comes in contact with the upper area in ordinary flexion, with the middle area in the semi-flexion, and the lower area in ordinary extension, this part, whereas the remaining part is only during full flexion. Now let us look at the applied anatomy. Now applied anatomy, here dislocation is common, dislocation fracture, so dislocation of patella. So it is one of the common bone which dislocate, just like in the upper limb it is the shoulder dislocation. Here we have this dislocation, and this dislocation occurs very commonly on the lateral side. So lateral dislocation of patella is more common. What are the reason why it happens? So this is because of there is a upward and lateral pull. So always whenever you stand, there is upward and lateral pull of your quadriceps femoris, that is a tendon of all the four muscle. So this will actually cause a patella to move laterally, and it will dislocate, it will not come back to its articular. So but normally it is not happening in you and me. So there are some natural preventing factors are there. So there are 3 preventing factors which will prevent this, and if these factor, any one of these factors fail, then the lateral dislocation happen. So one is you have the more forward projection of lateral femoral condyle. So if you see the lateral femoral condyle with the medial femoral condyle, lateral femoral condyle is projected more forwardly. That will one facilitate, it will give the more area for it to play around, and there is also a more prolonged insertion of vastus medialis on medial border compared to your vastus lateralis. If you see, remember this one, this is the medial border. So here we said only this is the entire, this was your vastus medialis, whereas here it was the reverse of it. So lateral border, the vastus lateralis was only present in the upper 1/4, whereas the medial border, this will always keep it towards the medial side, so thereby preventing it to go from the lateral side. So another factor is the prolonged insertion of the vastus medialis on medial border of patella. This also is one of the reason. And one more reason is here you also have the remaining part of it. We said the remaining part is a medial patella retinaculum. So this also caused the pull. So the pull exerted by a medial patella retinaculum also ensure that it is pulling it this side. This muscle is also pulling it this side, and you have more lateral area, so that also will prevent that it remain in this side. So these are the three factors which prevents the patella from dislocating laterally. But any of these factors are failing, then patella will dislocate laterally. So other applied aspect is fracture of patella. And patellar fractures are due to direct injury. So direct blow, you fall on your knee with the bent knee. So direct blow to patella. This can happen in the road traffic accident or anything. So when this happens, this will cause a fracture of patella. So it can fracture into one piece, two pieces, or two or more pieces. And the other one could be, this is a direct injury. Other indirect injury will be, there is no direct, that is due to pull. It is due to sudden and forceful contraction of quadriceps femoris. Nothing but your medial, lateral and superior, everything is pulling up. Forceful quadriceps femoris. So this also can cause the patella to break into transverse. So thereby this is the patella like this. Here you got vastus intermedius, rectus femoris, then this is vastus lateralis, and this is here medialis. So all these together we call this as a quadriceps. So this pulls up, so a crack may appear in the center. So this is what we call as a transverse fracture of patella due to sudden pull of your quadriceps femoris. And I already told you, since the patella do not have periosteum because it is a sesamoid bone, so no periosteum means there is no union of fracture. So no union of fracture happens. Natural union will not happen. So thereby what is required is we have to take the metal wire and we have to suture it. So then it will remain closer. So then it will help to, and even some bone cement may be required to allow it to fuse. Now there is with relation to the ossification, there is one interesting part is there. So here the patella ossifies from various ossification center. They appear between 3 and 6 years. Not important for you. And they all will unite and they form a single center. And by the time of puberty, the patella is totally formed. Ossification is complete. But there are some abnormal ossification center. So in that case, what happens is the patella may not unite. So that means there is a failure to unite, a failure of union in your ossification center. So if this happens, so what happens is now patella will be there into two pieces, one patella. This is what we call bipartite. If it is 3 pieces, you call this as a tripartite patella. So this is important because if a person has complained of an injury in the patella, direct or indirect, and he may be having a bipartite or tripartite patella, so then we have to differentiate. So how do you differentiate a fracture from this congenital anomaly? So if this condition is present, this is always bilateral. You take the X-ray of the other side, you will find this will be there on the other side, and a fracture will always have a sharp margin, and a natural thing like this will have a smooth margin. So sharp margin will be able to differentiate this. So let us see the images of these which I told. So let us see the images of things. So first I wanted you to see the dislocated patella. So here there are many images are there. So this is a simple thing. Here we can see. So I'll take this image. Then we can even look at fracture. So fracture of patella, if you see, this is the side view. We can see there's a transverse fracture is there. And the treatment part, I told you there, because of lack of periosteum it won't unite on its own. So this is one. And finally we can even see the abnormal ossification giving rise to bipartite. Let us see if it is. Yeah, here we have this bipartite patella. Because of failure of fracture. Here we have both bipartite and the patellar fracture. This we can take. Okay. Now we'll add these images one by one and we'll see the same thing. So first is your fracture. This is your patellar dislocation, lateral dislocation. How do we know this lateral? Because this is your tibia medial bone. Here you have the fibula, if you can see in the background, fibula, which is the lateral bone. So this is the lateral side, this is the medial side. So here normally the patella should be somewhere here. It is dislocated laterally. So that is a lateral dislocation of patella. Then this is your side view or lateral view. Here you can see due to pull of your quadriceps femoris, it has caused a transverse patellar fracture. So why that happened? Because the lower part is your ligamentum patellae will hold, upper part is getting pulled, so it get cracked. So that is transverse patellar fracture. So since it is not having a periosteum, it will not unite naturally, so we need to put them together. Now you see in this picture, there are two nails are passed and there is a wiring is done, and this wiring is like a figure 8. This is a AP view and this is a lateral view showing this. So this is how you have to keep the patella united, otherwise patella will not unite at all. And abnormal ossification can give rise to, or I think nothing but the failure to a secondary ossification. Secondary ossification fails to unite with primary ossification center, and that will give rise to two pieces of patella. So this is one piece and here is the other piece. Please observe the margin, it is very smooth margin. So this is your bipartite, whereas here you see the margins are sharp, that is your patellar fracture. This is how you differentiate. This can be again 3 pieces also, depending on what. So hope things were easy. If you have any question, get back to me.